Okay, so we've got Sam Wynne doing her cardiology assessment. Number 1106928. You've got 1 minute, Sam, to do your notes.
Okay, thanks. I'm good.
You're all good? Okie dokie. Cool. So here's your first ECG. There it is.
That's number 8.
Number 8. Cool. So your case is a 32-year-old female, seizure, postictal on your arrival. Has a history of epilepsy, which is well controlled via medication, nil injuries. Okay.
That's all.
That's all you've got, yeah.
No other vitals or anything.
No vitals, no.
Okay, so let's just do the general impression. So looking at it, it looks regular. Nothing ugly is standing out. Doesn't look particularly fast or slow. Just go over the tech errors. AVR is negative. Calibration spike. Just count that. So it should be 10 millimeters, which it is tall. By 0.20, which it is. Paper speed should be 25 millimeters a second. Doesn't actually say it on here, but I'm just assuming it is. Wave progression. Wave progression looks normal and consistent. I'll just work out the rate and if it's regular, so I'll just mark P waves. And move it along. Cool, so it's regular. And I can use the 1500 method. So we'll go 1500 divided by how many small boxes between the R waves. We've got 5, 10, 15, 16, 17, 18. So a rate of about 83. And it's regular. Let's move on to the P waves. So we've got P waves in all the leads. They look quite peaked, especially in lead 2. And we've got QRS to every P wave. P waves also look a bit long, so we'll just work out. So the PR interval is 0.24 seconds, so that's longer than it should be. So thinking of first degree heart block. don't have any pathological Q waves, no wide or no downward deflections. QRS complex. No wide QRS, so not thinking bundle branch block. I'll just have a look at the ST segments for any elevation or depression. Looking at the J point. Yeah, no elevation or depression that I can see. T waves all look, there's T waves in all the leads, and they look pretty normal. So just with the peaked T waves, I'll just check how tall they are. Just in lead 2, look like they could be tall, so I've got 2.5, so that is 2.5, which could indicate some right atrial enlargement, and kind of TP shaped, which will indicate that as well. Just work out the cardiac axis, so leads 2, no, leads 1, sorry, the R wave, about 6, no Q wave, and then the S about 3, it's about 3 for that one. Just make and then AVF, two minus no Q wave again, minus the S wave, it's about 0. I'll just mark that out. 3. We go around 10 degrees, so it's normal. And normal axis. Alright, so we'll do the interpretation. We'll go for 1st degree heart block with some right atrial enlargement, with P polymal waves in lead, especially in lead 2, which indicate the RAE.
Cool. Okay. So that's at 6 minutes 40 seconds. So just 2 questions. Is a 1st degree heart block always a concern?
Not always. Some people just have that, live with that, but it can progress to 2nd and 3rd degree, so it does need to be monitored and watched.
Okay. And what are some conditions that could cause RAE?
They've got pulmonary hypertension, so like lung, like COPD and stuff can cause that. Tricuspid stenosis, and tricuspid regurgitation can also cause it.
Okay, cool. Alright, so we'll end it there. Okay, so we've got Sam Wynne doing her 2nd ECG interpretation, so she doesn't want a minute's note, so I'll give you the ECG here.
Number 7.
Number 7, alright, so it's a 60-year-old female complaining of a headache, central chest pain radiating into the jaw, short of breath on examination, medical history, she is a heavy smoker, has ischemic heart disease and stage 2 moderate hypertension. Her blood pressure is 160 on 100. She openly does not take her prescription medications, which are Cilazapril and Diltiazem. Okay, so you can get that information anytime you want throughout the assessment.
Okay.
Yep.
So to start now.
Yep, cool.
Alright, so general impression, well, doesn't look very good. Looks quite fast, and there's noticeable elevation in quite a few leads. I'll just go over the tech errors. So we've got a negative AVR, we've got calibration spike of 10 by 0.20. Our wave progression is pretty poor and hard to see with the elevation. How old was the patient again? Sorry.
60-year-old female.
60-year-old. Cool. Just work out now if it's regular by marking P waves. Moving along. So it is regular, so I can use a 1500 method for this one. So I've got 1500 divided by the boxes between the R waves, so 5, 6, 7, 8, 9, 10. So 1500 divided by 10 is 150. Yeah. Tacky at 150. Just looking at P waves. Got P waves in month 1 and 2, and ABR, ABL, ABF. It's just hard to see them in the other leads because of the elevation and also the very large R waves. But in the leads where we can see it, we do have a P wave to every QRS. And the PR interval is less than, let me just double check the looks like it, yeah, less than 0.20 seconds. Q waves, don't have any, I can't see any pathological Q waves, no wide or downward deflection Q waves. QRS complex, they don't look wide, but I'll just measure them. They look okay, so I'm not thinking bundle bunch block, although I can't work it out in the elevation leads. QT interval. I need one.
So we'll just keep going from now.
Yeah, I'll just add them in to combine them. Where were they? QT interval. Looks a little bit prolonged in lead 1. I can't really tell. Just move on to the obvious ST elevation. So we've got elevation in leads 1, 2, V1, I should say V2, V3, V4, and we've got reciprocal changes. I've got depression in lead 2, 3, E, V, F. And if I did a posterior V depression?
So if a posterior ECG, you see significant ST depression in V7 through V9.
So more reciprocal changes there. So definitely a STEMI. I just did waves as well because they're quite big. So if I go, thinking left ventricular hypertrophy will go from leads 1 and 2 to the S wave, and 2 is more downward. It's about 2 mils. And V5 has the most upward R wave. I've got 5, 10, 15, 30, 34, 34 plus 2, so I've got 36, so it's more than 35. So that would be left ventricular hypertrophy. Just quickly work out the axis.
So you're sitting at 7 minutes at the moment.
Okay. The axis looks. Just do it quickly because I don't have time to work it out properly. Normal. If I was doing the thumbs method. And so the interpretation, I've got septal anterior STEMI with some lateral involvement as well, and then
Okay, start again. Yep.
so just do that whole interpretation again.
Yep.
So I've got sinus tachycardia with a septal anterior STEMI. Also have some lateral involvement, and we've got left ventricular hypertrophy.
Yep. Okay, so 2 questions. What information in her history corresponds with the LVH scene?
So she was a smoker, I think. Yeah, smoker. She already has heart disease. Hypertension.
Yep.
Yeah, she's not compliant with her meds either.
Okay. And question 2, what do reciprocal changes show?
So they show the opposite view of the heart. So where you've got elevation, the opposite leads will should have depression. So like this for this one we've got depression in 2, 3 and AVL, which are the inferior leads. Sorry, AVF, which are the inferior leads.
Cool.
Yeah.
Alright, we'll stop it there.